Good morning, everyone. It's a pleasure to be here. Thank you, Dr. Aditya, for including me in your IC. Today, I'll be talking about lens fragmentation devices in cataract surgery, and I'll be focusing on a device called the MyLoop or the MeLoop by Carl Zeiss Meditech. So, basically, the dense cataract has been one of the greatest challenges for most surgeons worldwide, and owing to the lack of epinuclear layer, cortex, fragile capsule, and laxity of zonules, it is a challenge. And when it's complicated further by polydilating pupils, pseudoexfoliation, and subluxated cataracts, it can be quite a tough nut to crack. So the options that we usually have for hard cataracts is some surgeons just prefer to do an ECC or SICS, but you have a large wound, residual astigmatism, and more cornea and iris handling. You can always do a divide and conquer or stop and chop technique, but this requires more phaco time, more phaco energy, and endothelial cell loss. There's, of course, the phaco chop technique, but this requires a longer learning curve, more surgical skill, and centrifugal forces are used, which can cause stress on the zonules. There are a few other pre-fragmentation devices, such as the Akahoshi pre-chopper for pre-fragmentation, but this does not get to the tough posterior plate. This also includes the femtosecond laser nucleotomy, which sometimes cannot penetrate the tougher posterior plates. It can be expensive and less accessible. So the idea with which this instrument was developed was that it's difficult to physically break a piece of hard cheese, whereas with a wire or a loop, it's a lot easier to cut the cheese. So with this, we come to the device called MyLoop or MeLoop. It's a microthin filament loop made up of a nitinol alloy with super elastic properties mounted in a pen-type actuator. It has a handle, a sliding actuation button, and a nitinol filament loop, which contracts to 1.5 mm and expands to 10.5 mm. This is the MeLoop Generation 2, which is now available. The only difference between this is, if you can see number 5, they've added these bellows for better holdability and handling of the device. So it has the shape of the capsular bag. So if you see the cross section of it, it's not circular, it molds to the internal contour of the capsular bag. So now let's see this device in surgical action. Okay, so this is a dense cataract. We see that a complete hydrodissection is done. It's very important that the capsulorhexis is complete and intact and the nucleus is well rotating. First, you completely retract the device, insert it, and open it up under the capsulorhexis. So it's important to, at least for the first initial few cases, stain the capsule so that you're opening it up under the capsulorhexis. A second instrument is inserted and the nucleus is held down while the nucleus is fragmented. The actuating button is slided backwards to retract the instrument. It can be turned 180 degrees and this can be further chopped into 4 quadrants. Some surgeons prefer to just chop it into 2 quadrants, which is adequate. You can see that this is a dense black cataract, for which a lot of phaco energy would have had to be used. But the MyLoop fragmentation makes it much easier with post-op day 1 clear corneas. Moving on to more complex cases such as small pupils with pseudoexfoliation. This is a case in which a pupil expansion device is used, the Maligan ring. So this goes to show that you can use pupil expanders with this device as well. Again, a complete hydrodissection has to be done to make sure that there is space between the nucleus and the capsule for this device to slide through. So once you insert it, there used to be a black band that had to be at the incision, but now you have bellows, which doesn't allow you to further insert the probe beyond the incision. Once the nucleus is completely encircled, I cannot stress the importance of using a second instrument more. It's very important to hold down the one pole of the nucleus, because the nucleus can easily tilt upwards while you're fragmenting it, and this itself can cause stress on the zonules. The second cut is done, and you see that the instrument does not snag the pupil expander or cause any other issues. Basically, here a centripetal force is used rather than a centrifugal force. So for dense cataracts as well, it causes minimal stress on the zonules, which is why we can also use it for subluxated cataracts when the subluxation is about 3 to 4 clock hours. So you see that this is a subluxated cataract. Here, can you see the silvery reflex? In most cataracts, as you pass the loop posteriorly, you can see a silvery reflex as the snare encircles the nucleus. The force that's used to crack the nucleus is towards the center rather than the periphery. So the stress on the zonules is minimal. This is a second cut, which is done. And we can see that the nucleus has come out of the bag a little bit, but the bag is still intact. And the ZD has not increased. A CTR is placed and a lens is placed as usual with a clear cornea post-op day 1. So some noteworthy pressure points are that a complete hydrodissection has to be done. The loop has to be passed under the rim of the capsule. A second instrument has to be used to avoid tilting. Make sure that you don't snag the capsule during removal of the instrument. And the viscoelastic that has to be used is HPMC and not denser viscoelastics for smooth movement of the loop. Before we reinsert the instrument before the second cut, it's ideal to remove the instrument, inject some viscoelastic, and then reinsert it before the second cut. And before the second cut, it's ideal to rotate it only by 40 degrees because as the loop is ensnaring the nucleus rotates by itself. So can you use this for SICS as well? Yes. So we say that there have been studies done where SICS has been used for MyLoop with much smaller incisions, having cut the nucleus into 2 heminuclei and then removed each heminucleus. So smaller incision causes less induced astigmatism, better maintained AC, no sutures, and you can make a smaller rhexis even for denser cataracts. So we did a study of 50 eyes of grade 4 to 5 nuclear sclerosis and found that the CDE intraoperatively was much less with the MyLoop group and the endothelial counts at post-op 1 month was higher with the phaco with MyLoop group. There have been multiple other studies that have been done to come to the same conclusions. These are just some of the studies and some interesting cases as well where pars plana vitrectomy with the MyLoop has been done, where it was introduced through a sclerotomy and created for the fragmentome to cleave the lens into smaller and more manageable pieces before the phaco-fragmentation was done.
Supriya, we're running short on time, so
yeah. Okay. That's my last slide.
So
minimal damage and complete nuclear fracture, less phaco time, energy, etc. This is an excellent addition to your surgical armamentarium for dense cataracts. Thank you very much.
Supriya, I have a question for you. So what is the learning curve like for using the MyLoops? Because whenever I see your videos or Dr. Srikanesh's videos, I'm very tempted to go back home and use it. But there does seem to be some amount of movement in the nuclear bag complex whenever you use the MyLoop, and that's kind of a mental block for me to go ahead.
Exactly. So the perception is that it's a very bulky device inside the eye, but it's actually a 0.3 micron diameter nitinol filament. So it's actually very thin and flexible in the eye. It doesn't touch any other tissue or endothelium, etc. It's very easy to use. So basically, if you keep these pressure points in mind, saying that a complete hydro has to be done, it has to go under the capsule, etc., it's a very smooth and easy learning curve. For me, when I started off, I had no issues with using the MyLoop with the right instructions.
Thank you. Yes.
Yeah, a very small rhexis would not be ideal. 5 to 5.5 mm as per usual. You don't need to make a much larger rhexis.
One of the other advantages is that you have a mechanical delineation. When you use the MyLoop and then rotate it, the cortex gets cleaved, and then cortical removal is much easier.
Thank you, sir.
Thank you so much for your patient listening.